Hello, I'm David James. I'm a paediatric emergency medicine consultant at Southampton and the emergency care lead for Healthier Together. This is a short video about common causes of cough and breathlessness in young children. And it's going to demonstrate a new pathway we've written for this winter for primary care doctors in assessing and treating such children. To navigate to the pathway, please go to the Healthier Together website you see before you. Hit Professionals, GPs, Paediatric Pathways, and you'll see down here, cough and breathlessness under 2 years. Now, why are we doing this now? Well, already we're seeing an increased amount of children presenting like this, certainly to my emergency department, and I suspect to your GP surgeries and other primary care settings. The reasons for this are multiple. Obviously, we've just come out of lockdown a few months ago post-COVID, and the experience from the Southern Hemisphere was that they saw a significant uplift in cases like this when they came out of lockdown, particularly down to RSV. They had a really big RSV surge in the Southern Hemisphere, particularly in Australia, towards their late summer, and we're already starting to see this. So it seems like a really good time for us all just to think about how we manage these patients and the differences that we might see this year compared to a normal year. This pathway is deliberately designed for children up to 2 years. That's because the traditional boundaries of bronchiolitis and viral wheeze seem particularly blurry at the moment, as those between 1 and 2 have not often been exposed to RSV due to its very low circulating levels last year. Therefore, this is often their first significant respiratory illness, and the management between bronchiolitis and wheeze can get a little blurred. This pathway is a combination of established pathways we already have on Healthier Together for bronchiolitis, croup, and wheeze. So, when you're assessing these patients, the important things for you to consider are listed here in the table. Things such as colour and activity. And it doesn't matter if they're a traditional wheezer or a bronchiolitis in cases like this. These assessment parameters are useful whatever the final diagnosis is. Blue and grey colour, unable to rouse, confused or drowsy appearing infants are obviously a significant concern. It is a red factor. And the way to use these pathways is always to look for the red features first. If they're not present, look for the amber features. And if there's none of those, green. A pale or mottled child who perhaps is just very sleepy is an amber. And without those, they're green. Moving down to respiratory, you'll see some values here. Now, these are values which are lifted directly from our bronchiolitis and viral wheeze pathways, which are in turn devised from the NICE guidelines for bronchiolitis, recently updated, and from the BTS asthma and wheeze proforma. A respirator greater than 70 when under 1 or greater than 40 should mandate immediate referral to paediatric services or paediatric ED, depending on your local referral pathway. SATs have recently become quite controversial, and you may have come across some people talking about the new NICE guidelines, which have moved some of the criteria from 92 to 90. With the crossover between bronchiolitis and viral wheeze, and with the best available evidence that we have, it seems to us that the most appropriate referral point would be SATs less than 92%, or of course visible cyanosis, regardless of age or presentation. The caveat to that, however, is that there will be a few babies who are traditionally bronchiolitic, crackly, more than wheezy, and who are older than 6 weeks, who have no other red features, such as tachypnea, grunting, respiratory distress, and are well hydrated and perfused, who may have SATs of 90 or 91 using a reliable paediatric SATs probe in primary care. It's possible for those children to be discussed with a professional, or occasionally even to be safety netted, but we would strongly suggest that these patients are referred into hospital care. Looking down there, you'll see some red features, such as stridor at rest, which comes from our Croup pathway. Stridor at rest should always be referred. Stridor only on exertion or distress can be discussed, and you'll see there the difference between mild and moderate respiratory distress and severe respiratory distress. When we talk about respiratory distress, we're talking about signs such as recession, intercostal or subcostal, such as tracheal tug, head bobbing in younger ones, or perhaps nasal flaring. Circulation and hydration are important. Obviously, factors such as heart rate in wheeze, or certainly capillary refill time, are useful markers. Cap refill particularly because some of these children, a very small minority of them, of course, this could still be the presentation of a significant bacterial infection, and therefore perfusion is really important. Feeds are also really important when it comes to assessment of certainly the younger babies. What proportion of their normal feeds are they getting in? Are they less than 50%, in which case they should be referred? Are they between 50 and 75%, in which case they should be discussed? Finally, other factors which will always make you need to refer in include sudden onset symptoms, or of course parental concerns around inhaled foreign body, which is always something we have to have at the back of our minds. And then some traditional factors which would make you always discuss these patients. So fever for more than 5 days, risk factors for severe disease, so congenital heart disease if they're immunocompromised, if they're chronic lung disease, chronic congenital heart disease, or if they're very young or express. These should be discussed. And what we'll do now is we'll just have a quick look at the different pathways that this extends to. So again, back into where we were, you'll see here that there are also pathways for bronchiolitis, for Croup, and down the bottom, or rather I should say up the top, acute asthma and wheeze. So bronchiolitis is available here. This is the bronchiolitis one. This is for when you are feeling confident that the diagnosis is bronchiolitis. So these are often your younger infants. The chests are more crackly than wheezy. They won't have a particularly prolonged expiratory phase. The management of these patients, as you know, is supportive. So it's oxygen if they require it, feed and fluid support if they require it. And if you find a baby in the red camp that you're sending in, your treatment before the ambulance arrives is probably no more than oxygen. You'll see here that they all link to the patient advice sheets, which I'll just click on one so you can see. This is the bronchiolitis safety netting information. And a factor that I always like to demonstrate is the SMS share function, which allows you to pop the parent's phone number in and send it directly to them. Just going back to what the other pathways are that we have. Croup, which is here. So Croup, again, as with everything, Croup breaks things down into green, amber, and red. Red factors would lead to an immediate referral. Please, if you're able to, it's good to get steroids in as quickly as you can if the child's not too distressed. That can be single-dose Dex or the first dose of prednisolone. If you're able to deliver an adrenaline neb using adrenaline from a crash trolley, if they are really working that hard, we would also support that in primary care. And obviously oxygen as needed. The majority of patients may well be in this amber group. And certainly in discussion recently, it's been felt that it's appropriate for some of these to be kept perhaps in a waiting room after a dose of steroids to see if they improve. And if they no longer have stridor at rest, perhaps they can go home. Otherwise, of course, we'd be more than happy to see them in hospital. And finally, acute asthma and wheeze. So again, going back to our conversation about 1 to 2 year olds, the older group of these patients are much more likely to be wheezy. And of course, the big difference between management of bronchiolitis and viral wheeze is the administration of bronchodilators, namely inhaled or nebulized salbutamol, and its relevant value. So children who are predominantly wheezy, and certainly who are over the age of 1, we would support the use of salbutamol for these patients in primary care. And generally, we use somewhere between 2 and 10 puffs. 10 puffs is normally an initial dose. If they are amber, and certainly if they're red, we would expect them to have at least 10 puffs or a nebulizer before being referred in. Going home, you'll notice here again that there is a link to a hyperlink here for a viral-induced wheeze plan, and this is what we would expect people to be sent home with from primary or secondary care. So I hope that video was useful. I hope that I've shared some useful information about the management of bronchiolitis, viral wheeze, and Croup in what's likely to be a busy respiratory season. If there is anything else that you would like to know, you can find some contact us details on the Healthier Together website, and I'm more than happy to answer any additional questions. Thank you for watching, and enjoy your winter.